Good afternoon, everyone, and welcome to the fifth episode of Savikalpa Sanchaar, a platform where we discuss common and not so common lifestyle disorders and engage with experts to learn about how to best manage them. Today, we are privileged to have Dr. Dhruv Zutshi in our midst. Dr. Zutshi is Senior Consultant Neurologist at Fortis Hospital, Vasant Kunj. Welcome, Dr. Dhruv.
Thank you so much. Thank you for having me over.
It's a pleasure to have you here with us, sir. Today, we are talking about one of the most, I suppose, common headaches that a lot of us face, and that is namely headaches and specifically migraine. If we can learn from you to just start for a very simple layperson understanding, what exactly is a migraine?
So basically, migraine is a situation wherein a patient or a person experiences a headache which can start from one part of the head, then spread to the other parts. The part may not always be fixed. Quite often, patients may feel that it happens only on one half of the head and may last from a few hours to up to days at times. Now, the thing with migraine is that most often it is just dismissed as a simple headache. That people feel that I just have headaches and I take something, I either take a Combiflam or a Crocin or Saridon, whatever is there at home, and after a while they feel relieved. What they don't realize is that they could be having simple episodic migraines. So migraines are broadly in two ways. Like you may have episodic migraine, which could be one-off episodes, nothing to worry about. And then you could start having chronic migraines. Now these are the patients who are generally in distress and require real medical care. They need to visit the doctor. Now why migraine is just a headache? So why is it so important socially? So in the US, they conducted a study about a couple of decades back to see that they saw a lot of people taking leaves, absentees from work. And over a period of time, they realized that there was about nearly $20 to $30 billion of loss because of people not reporting to work. Now, these were just simple headache patients. Didn't have any life-threatening illness. However, their efficiency really dropped.
Yes.
So even if people with their headaches continue to work, couldn't really do the work and would take huge number of hours, made more mistakes. So that's when it actually realized that this is a real medical problem and needs to be dealt with in a better way. So that's how migraine became a popular thing. People started coming to know about what a migraine really is because headaches have been there for centuries.
Absolutely.
And once in a while, only 1 or 2% headaches are secondary headaches, or the dangerous ones that we like to get scared about. Otherwise, most people will have regular headaches, and of all the headaches in the society, nearly 85 to 90% will be just migraines.
Will be migraine. All right. You touched upon a lot of subsequent questions that I had, so thank you for that introduction. And you mentioned about how in the US that there was this understanding that regular, frequent migraines and maybe other types of headaches which go beyond just a normal headache were leading to a lot of loss productivity and economic loss in particular at a economy level. We came across two studies from 2019 which did a population level, district level population level survey in Karnataka and if I remember correctly Tamil Nadu, where the studies suggested with an N of several thousands of persons surveyed that there's a prevalence of about 16% of migraine in that population. If one extrapolates that, Dr. Zutshi, to an India population level, then that would roughly translate to about 220, 230 million persons suffering from migraine. Is this number true? Is this...
Very much. At the community level, yes. And if you go at the gender level, then migraines, because it's an estrogen dominant thing, can go up as high as 30-35% in females and would be a little less in males. So if you look at the female suffering and if you even see the patients coming into the OPDs, they are predominantly females. The ratio is 3:1. So it's a big problem amongst females and especially in the reproductive age group.
Okay.
So after adolescence till the time they hit menopause, because they are high on estrogen, so females experience a lot of headaches. And
prevalence is greater in women than in men generally.
Very much. So 16% is a fairly good estimate. Of course, that includes predominant episodic migraines, and then some about 20 to 30% of that group would be chronic migraineurs. So it's still a huge number in our country, which is a big population of 150 crores now, close to. It's a big number.
And it would be underdiagnosed, therefore, because these were specific, let's say, researchers looking to understand what the prevalence is. But you mentioned that people are often confused about whether or not they have a migraine, and they assume that they just have a general headache and therefore take whatever medication is at home. How does one really differentiate between a normal headache and a migraine, and when should one see a doctor?
Now, what happens is that you can have stress-related headaches, which could be just one-off, and there generally will be an external stressor or a mental stressor which will be there. Then there will be a group of people who will keep experiencing regular headaches, but they'll be more often. It could be 2, twice, thrice a week, sometimes thrice a month only. And generally what they presume is that I went out in the hot sun, so I got a headache. I got tired, I got headache. I worked a lot, I got a headache. I didn't sleep well, so next morning they have a bad headache. And wherever they feel, it could be a hangover thing, or it could be a simple hangover headache. Now what they realized over time is that all these things were just triggers for migraine-like headaches. So these people were experiencing typical migraine-like headaches. However, because it was not occurring otherwise as frequently, so they would always relate it to these triggers. So when you read about migraine or you find out about migraine, you'll realize that there are so many triggers and a lot of them are just these. So an exhausting
individual choice, or like the triggers, are there a common set of triggers or do they vary from person to person?
Now, there are a few triggers which may be common to a lot of them, may not be to all of them, but most migraineurs, especially the ones who have chronic migraines, by chronic I mean people experiencing 15 or more headaches in a month or headache days in a month, they know their triggers because they've been dealing with this problem, and they try to find out at their personal level as to why is the headache occurring. Even if they do not know they have a migraine, quite often people don't seek medical help. They just want to make some lifestyle adjustments. They would like to see if reducing their stressors might, make things better, or they try to look after their triggers. So the actually intelligent and well-read people quite often are very aware of their triggers. They may not know that they are still having a migraine or that trigger is triggering that migraine headache, but they quite often report that I do this happens, I do this happens, I go out, it happens, I can't go out for a picnic, I can't move around. So they are quite aware of, they start picking it up over a period of time.
One of the objectives obviously of this effort is to build that medical awareness. So if one does see that the frequency of, let us say, headaches one is experiencing is above a certain level of tolerance, then one should seek medical intervention. And what is the kind of which doctor should one approach when we experience, let us say, what you are classifying as migraine or chronic migraine?
I'll tell you that. Now, if you see as per the International Headache Consensus, what they suggest is that somebody who's experiencing 4 or more headache or headache days in a month. And there could be people who could have one headache which could last for 2 days or 3 days. So they might have only 2 headaches in a month and may not say he had 4 headaches, but he'll have at least 5 to 6 headache days. So if anybody is experiencing 4 headaches or 4 or more headache days in a month, he or she is basically quantifies for a regular treatment, at least for a short while, till the time you bring down the frequency, and then again you can taper off the medicine. Then there will be a set of people, as I said, who will be called chronic migraineurs, who will be experiencing 15 or more headache days for a minimum period of 3 months in a year, and those patients will require a longer treatment. And depending on the age of the patient, the gender, the lifestyle, the work that the patient is doing, you actually tend to choose the medicine. So there are about 6, 7, 8 medicines which are available in today's time, all of them very effective in bringing down frequencies. Sometimes you may use a combination of medicines, but it all depends on what the patient gender and what patient lifestyle is. So all those things are very important. Of course, you always want to educate the patient also about managing their own triggers, because that itself may help them a lot. So that's how we generally go about. But these are the broad ways when we decide. Secondly, sometimes patients are doing very high-end, very important jobs. So then even a single headache, if it's making them impaired for working, and especially if they're working in intelligence kind of areas, so they can't be off the work. So then they seek treatment even for a single headache. And for that, you have very good SOS medicines in today's time. You have injectables, you have nasal sprays, of course you have oral tablets, and any patient can make a choice as per what they feel comfortable.
Just to understand the types of medication that you mentioned, so these are preventative medicines that, for example, the orals or the injectables, the nasal sprays, they prevent the attack from occurring, or do they reduce the intensity of the attack?
So basically you have something called as a SOS treatment, and then you have the prophylaxis.
Alright.
So the prophylaxis is where you advise a set of medicines irrespective of the headache. Whether the patient is feeling comfortable, having a headache, not having a headache, the patient continues to take those medicines, and that over a period of time reduces the frequency and prevents the headache from occurring. So that's the real treatment of migraine. Now that's where our community or our country is really lacking, because there's generally no awareness. I've seen a lot of patients over the years who visited their general practitioner, who visited the physician, who made a correct diagnosis of a migraine, but never put them on treatment. He told them you have a migraine-like headache, gave them an SOS medicine, whichever he was comfortable with, and just told them you can have this. And the patient ended up having 20 times in a month. And the patient says that I take this medicine, I feel good towards the end of the day, but next morning again I have the headache. Then subsequently, so the patient starts consuming analgesics mostly, and quite often may land up with kidney failures.
So these are standard analgesics, NSAIDs, which are used for various other types of pains?
No, not always, but see, in the rural background in India, Combiflam, Saridon, the drugs which have been advertised on television are the ones which are easily available, over the counter hai. So patients just consume them. And they are regular analgesics. They do help in the headache also, at least in the initial parts. And then you have some slightly better ones. They are still NSAIDs, like naproxen sodium with domperidone. So they are slightly better combinations, a little more effective, and probably a little less in side effects compared to the diclofenac, which is Saridon and other ones. And they are a little less dangerous when consumed over a period of time. However, if taken really over a long period of time, and that would mean sometimes 30 days, 50 days, 60 days, you will land up with rising creatinine levels or with kidney dysfunction. So they are dangerous drugs.
Especially for people who are suffering from this chronic, let's say migraine in particular.
They are the ones who abuse them basically. Then you also have a lot of people getting affected, addicted to opioid drugs. Like you have tramadol, tapentadol. So people sometimes just get hooked onto them, and they are addictive in nature. So then they start abusing them, and that's another big problem.
In terms of what the potential
very much
adverse effect.
Adverse effect is, there's another thing, we'll talk about that in a little while, that how painkillers also induce headaches. So that's called as medication overuse headache.
Medication overuse headache.
So that itself is a big thing, and now the patient gets stuck in a cycle. They take that SOS medicine, they feel okay, then they keep doing it for a while, couple of months, 3 months. Now that medicine, mostly these ergot alkaloids like sumatriptan or rizatriptan, they have a tendency to now start inducing the headache. So it's like an addictive cycle. You have to take that medicine. If you don't take it, you will get the headache. So
that builds dependence there.
That's a complete dependence. The patient just can't go off it.
Which from the sound of it sounds more acute than dependence on NSAIDs or even opioids for that matter, where there might be tolerance, but it is not leading to...
No, it starts leading to headaches. Medication overuse headache is now a proper defined entity. It's no longer just somebody just making a statement. It's actually described, and you have to break the cycle. You have to counsel the patient to use other analgesic, whichever, even if they are not getting adequate relief, you put the patient onto short course of steroids as well to bring about a cycle change. So it remains a real problem.
Because the absolute harms are more limited if you are able to switch.
Yes, you have to switch. Otherwise, it leads to a lot of problems to the patient.
Understood. Are there non-medical interventions that, people can sort of practice, whether it is diet or exercise, perhaps meditation, yoga, which can reduce at least the intensity of attacks?
For chronic migraineurs, I also personally tell them that they have to get 7-8 hours of sleep. Extremely essential. Lack of sleep is probably the biggest trigger ever. If you see the general population, if they can do some yoga to reduce the mental stress, very helpful. Then what I generally advocate further is that be well hydrated, eat your meals on time. Skipping meals, fasting is a big trigger. So especially in communities like amongst the Muslims, when they practice during Ramzan, month of Ramzan, the number of headache patients who are coming to the OPD are very high. All the females are fasting, males are fasting through the day. Towards the end of the day, they have severe headaches. And they may not realize that the migraine got triggered because of the fast.
Because of the fasting.
So again, having regular meals. So basically, it all comes down to maintaining a good lifestyle. Nature wants you to do that. And when you go against it, then of course you are inducing trouble, or you're inviting some trouble. Then summer months, headaches are very high. So general advisories are that if you have to go out, you can wear black goggles, you can use a good umbrella, put on a scarf, remain well hydrated, carry your water with you. All these things are very good. Caffeinated drinks are a big trigger. Among certain group of people, although there is a group of small people who might feel better after a caffeinated drink, but most patients will experience headaches after caffeinated drinks. That could include colas or coffee, tea, anything. Depending on the concentration, tea would be the safest one probably, the least amount of caffeine. And common triggers could be spicy food, but not for a very large population.
Okay, because in India, so we eat so much spicy food.
So it may not hold true for everybody. Yes, but hot weather remains, bright sunlight remains a big trigger. Mental stress is one of the biggest triggers and the most underreported. People go through subclinical depression and that keeps inducing the headaches, and they just don't realize what's happening, and because they are going through a different mental state, so they are not really able to focus on why the headache is occurring. It's just the depression triggering those migraine-like attacks, whereas everybody keeps saying this is a tension type headache and this is a stress related headache, but tension type headache is one of the commonest episodic headache, but not a frequent headache. If somebody is experiencing it regularly, then it's unlikely to be a stress related headache. So these patients do require intervention.
This is very insightful, Doc. Thank you for sharing from your decades of experience and understanding of the difference between headaches, migraine. You also mentioned, for example, tension type headaches, which is something that we see now spoken of more and more, but what the difference between that and, let's say, chronic migraine in particular is. Thank you once again, Doctor, for your time. Really appreciate it. And thank you for sharing your knowledge with the wider set.
Thank you for having me over.
Have a good day.
Thank you so much.